So welcome everyone. I'm Aida from London. I'm a medical student. I'm working at the National Hospital for Neurology and Neurosurgery with some of the neurosurgeons here, and very keen on neurosurgery. And thank you, Dr. Bennett, for inviting me in this meeting where we're gonna hear Professor Lawton, who I think needs no introduction. I don't think there is a living neurosurgeon that hasn't heard of him, hasn't read his paper, or hasn't admired him, as we all do. And yeah, I'm looking forward to hear his talks. I've already seen many of his talks, and it's never enough. So I pass on to Professor Hernesniemi for a proper introduction.
Hello, everybody. Welcome to this grand rounds. I will give a short introduction of Professor Michael Lawton for the Chinese and Japanese audience. Of course, he's world famous, but I repeat the most important facts. So, Professor Michael Lawton is the chairman at the Barrow Neurological Institute, BNI, in Phoenix, Arizona. And he's certainly one of the most important neurosurgeons of these times in the world. He became medical doctor 1990, then made neurosurgical residence at Barrow Neurological Institute by Professor Spätzle until 97. After that, he worked at USF close to 20 years and became the new leader at the BNI 2017 after Professor Spätzle. So how to become a good neurosurgeon? I never saw a person who wanted to be a bad neurosurgeon. Train hard, 2 words. So follow the way Professor Michael Lawton has done and is doing. There are different levels of manual skills. It depends on number of repetitions and length of career. That is the old rule. If you train something 10,000 hours, then you will be at the world top. And my own rule is that when you have spent 10,000 days in operation room, then you are at the highest level of your career as a neurosurgeon. Neurosurgery has 3 parts: operative skills, as mentioned, then research, clinical, and basic. Mainly clinical for practicing neurosurgeons, and teaching. Professor Lawton has written the 7 series, 7 aneurysms. Aneurysms came first, the book, then 7 AVMs, and 7 bypasses, and they are all translated also in Chinese. There's more than 700 publications, has attended numerous congresses, participated and given many live courses, and of course now during the COVID time has been in numerous webinars like this one of ours. Until now, he has done amazing more than 5,000 cerebral aneurysms and 900 AVM operations, more than 1,000 cavernomas, 1/4 of them in Brainstem, and as a young man, he continues every week. The figures will change. So you have to be excellent neurosurgeon to manage that, organizer, surrounded by a good supporting team, and the patients and society, and of course have a big catchment area, big population. For all this, Barrow Neurological Institute is the model for all the world. You should train your best young people. My teacher, late Professor Charlie Drake, told that if he cannot find that kind of people who become better than him, then he waits, and one day they will come. And certainly now, before Michael's chairmanship, so many fellows, residents were trained at Barrow Neurological Institute, and this work continues. A huge amount of most brilliant, skillful people will be trained there, and so the skills go further around the world. So thank you, Seiseni. Michael, please go ahead. You will speak now on Brainstem Cavernomas. We are waiting for this interesting lecture.
Thank you, Juha. Okay, let me get to my screen share, and hopefully now you can see my title slide there.
Yes, we can.
Perfect. Okay. Well, Juha, thank you for that generous introduction. Ada, thank you for that as well. I agree with everything you just said, Juha. I think you know, the secret to success is just loving what you do and always trying to be better. If you love what you do, and neurosurgery is certainly one of those things that's easy to love, then spending 10,000 hours or 10,000 days in the operating room becomes a real joy. And if you're always trying to be better, then there are endless questions that come up and endless things to research and figure out. And it's never gotten boring for me. So I think that to me has been the secret, is just to really immerse yourself in what we do here. Well, this is a topic of great interest for me now. I'm putting together 7 cavernomas, and as part of this, I spent a lot of time thinking about my experiences in the brainstem. So I'd like to just kind of share with you some of the thoughts behind that. So this is an experience and a talk that's based on over 1,000 cavernous malformations in the brain. The numbers in the brainstem is just, well, we probably crossed now 300, but you can see for yourself quite a few, about 1/3 of the experiences there, and then some additional ones in the spinal cord. The book is in progress. Some of the objectives of the project are to develop a taxonomy, actually a couple of taxonomies, not only for the lesions themselves, but also for the surgical approaches, to really advance this idea of tissue-sparing surgery, where we utilize the subarachnoid space rather than going through brain. And then to see if we can apply deep learning technologies to help us with the decision-making. Like with all the other books, I really enjoy the metaphor. And for this book, the metaphor is maps. Here's a picture of my home in San Francisco. I was there for a long time, and one of the real pleasures of being in the Bay Area was these open spaces. And you can see here, this is a look southward to San Francisco. You can barely see the city in the horizon there. And these are the headlands, the hills in Marin County. And if you were trying to get from this point back to the city, you can see that it'd be a long hike, and you'd have to go through a lot of hills and valleys to get there. And it can be tough to find your way. It's easy to get lost. But when you have a map like this of that same area, you can see these red lines through the green. And these trails and these mapping techniques really allow you to find your way and get there quickly and safely. And I think the same idea is what we've all become accustomed to in our cars these days. This is from my Tesla, and you put in your coordinates, you put in your destination, and you get a blue line that takes you from your home all the way to your destination. And that's really how we think. And one of the things that we have in the brain is a very similar thing. We have that in the form of the arteries. So as one of the first tenets, it's just that the arteries become this roadmap for us. And here's a paper from years ago that I finished with Lawton and Anna. And you can see here how we just completed this segmental anatomy. He had done a good job of describing the different segments of the arteries, defining the alphanumerics for them. We just completed them in the cerebellum so that the entire cerebral circulation has this alphanumeric system of segments. And these segments are handy because the arteries go everywhere in the brain. So if you can relate your malformation to the segmental anatomy on the arteries, then it can provide you with a way not only to find it, but also to get there. So this is the idea of using the arteries to get your way to the lesion. Now, one of the other ideas is this idea of triangles. When we look at these surgical corridors like this one, this is the corridor in the carotid cistern, and there are all of these little spaces to work in. And when you just look at an anatomical field like this, you don't often see them or don't see all of them. But when you train your mind to think of these triangular spaces, these anatomical routes, then you can begin to compartmentalize your approaches, and it helps to organize your dissection. So these are some of the triangles that I think are valuable in the surgeries that we'll be talking about. These are some more pictures from publications, but you can see down here in the center, these are the ones we talk about frequently for aneurysms: the optic carotid triangle, the carotid oculomotor triangle, and the supraoptic triangle. Over here, you can see what I call the bypass triangle. It's the oculomotor tentorial triangle because it gives you good access to vessels for recipients in the posterior circulation bypasses. Over here, we've got our ACOM triangles, the precommunicating and the junctional triangle, useful for the ACOM aneurysm. If we look down in the posterior circulation, we've got the vago accessory triangle, one of my favorites, subdivides into the infra and suprahypoglossal triangles. Here, these are useful for getting to pica. And here, the GCT, or the glossopharyngeal cochlear triangle, for tumors and for high-riding picas. These triangles really are everywhere we look. I think they're simplifications of this very complicated anatomy that we work in. And if you look around, you see them in the anterior cranial fossa, you see them in the middle cranial fossa, and posterior cranial fossa. So everywhere we look and see, we find these triangles, and it's, I think, really valuable to use them to guide our dissection routes to these access points for the cavernous malformations. These triangles really, by working through the triangles, get us to the surfaces of the brainstem. So we go from approaches to triangles to surfaces. We get to the spot on the brainstem where the lesion comes to that surface. And we want to try and pair the approach to that surface where we're trying to hit our target. These are just some illustrations showing the surfaces that get exposed with these different approaches here. Here's some more: the far lateral, retrosig, supracerebellar, suboccipital. All of the approaches will give you different regions. And so you really have to make sure that you line up your approach with the surface that you try and reach. One of the last concepts here before we go into the case studies are the entry zones. Most of the time, these lesions will come through the surface. They'll either be on or extending through the surface. And so the concept of a safe entry zone becomes less important for those. But when you're dealing with a lesion that's below the surface, that doesn't actually present itself right there on the surface, then you have to know these safe entry zones. And this concept has been around now for a while, but I think the idea of them being safe is really a matter of controversy. There are some areas that are very safe, and this is an example here, number 5. This middle cerebellar peduncle is a wonderful safe entry zone that I use a lot, and I'll show you. This Olivary safe entry zone is another. But then there are those that may or may not be safe. You know, there are varying degrees of safety depending upon where you are and how deep you need to go. So I think still, even though we've become a little comfortable with this idea of safe entry, there is variability, and not only in how safe they are, but how deep you have to go. So always you want to look for lesions that present on a surface that make it so that you don't really need to violate tissue. Now, one other concept that I think is important is this idea of surgical decision-making and taking on patients for surgery. We do this all the time with AVMs. We do it for other lesions as well. We have a grading system that just gives us some sense of what the outcome is likely to be. This is one that we came up with years ago for the Brainstem. I know Juha, you also made one as well, and my take was to really focus on the Brainstem, because for the other ones, you know, in the cerebrum and more accessible areas, it's a little bit easier to decide, at least in my mind, whether or not to do surgery. But the Brainstem can be difficult, and this is a combination of 5 variables that is very much like Spetzler-Martin grading, assigning points, adding them up, and drawing cutoffs. And not only is it similar in its application, but if you look at the different criteria, they're really the same criteria that we often think about for AVMs. It's a size, a venous component, and an eloquence factor. So the size, whether it's 2 centimeters greater than or less than, gives you a point or not. The eloquence is what we came to crossing the axial midpoint as our way of stating eloquence. The Brainstem is eloquent all the way through, up and down. So it really doesn't have meaning to say that some Brainstem cavernomas are eloquent and others aren't. But when they cross the midpoint, it's an indication that you get to those tracks that are either crossing or running straight up and down. And it also gets to this idea of how deep it is. So that was an important variable. The venous anomaly is also an important one because it complicates the resection, so that gets a point. And then if you think about the supplementary grading system for AVMs, it's age and hemorrhage and compactness. Well, compactness doesn't matter for these, but age and hemorrhage are the same. And we have cutoffs here of 40, just like for AVMs with 0 and 2. And we also have a very important component here for hemorrhage, the timing of the hemorrhage relative to your surgery, with the categories being acute, subacute, and chronic. And the reason that's important is that if you look in this illustration over here to the right, a cavernous malformation that's freshly bled has this liquefied hematoma around it that separates the malformation from the tissue, and it really facilitates the removal. And you get less of that as time goes by, so that in the subacute period, that liquefaction starts to shrink, and you lose it altogether at about 8 weeks. So this becomes the basis for these points. The idea here is that you want to capitalize on the liquefied hematoma, so it helps you not only separate the lesion from the brainstem, but also create that working space. By taking out liquefied clot, you're essentially creating workspace around the lesion that will be helpful. On the flip side, the chronically scarred AVM that's now gliotic and densely adherent is a bit more difficult to separate. And so for those reasons, the chronic gets 2 points. So at the end of the day, you end up with this grading scale, you assign your points. This is some data from our original paper, just showing how you could almost imagine a cutoff here, but the numbers were so small that we didn't have a good sense. We applied this recently. This is an upcoming publication with both my 300 cavernomas and Dr. Spetzler's experience. And we found that if you apply this, you really do get a nice fall off in outcomes that that matches the grade. So the higher the grade, the more likely you are to get a new deficit. And these two graphs show the outcomes in terms of final outcome or relative outcomes compared to pre-op. And in both cases, you see how there's a correlation between the grading and the outcome. And the way that that I think about these is to think about these as low grade, intermediate grade, and high grade. The high grades are the grade 6 and 7. These are the ones to be careful of. The grade 5s are also, you can see, have some significant risk. But in my mind, I think about these as low grade as being safe for surgery, intermediate grade being the 3s and 4s and 5s being mostly safe for surgery, and the grades 6 and 7 ones to be careful with. This is just some statistics showing the sensitivity, the area under the receiver operating curves to show that the predictive power of this grading system was quite high, almost exactly what we see with Spetzler-Martin grading. So on to the approaches. There are many corridors that get you to the lesions here. The main ones being either the sulci or gyri, the sylvian fissure, interhemispheric fissure, the ventricular system, working around the tentorium through the petrous bone of the foramen magnum. And I'm just going to now show you different examples of these approaches applied to these brainstem regions. So we'll start with this one. It was in the midbrain and the thalamus, and we'll start at the top and work our way down. This is a lady who presented with a homonymous hemianopsia, and I'll show you the imaging in a minute. If you look at her brainstem grading, this is a grade 3, no points for size or crossing the midpoint, or a DVA, but for age and for bleeding. Options include the following, but I chose this contralateral supracerebellar transtentorial approach. It's a very nice approach done through a torcular craniotomy, and here's the lesion. So when you study this lesion, let's look at this one in the center here. You really don't see this thing coming to any surface. It doesn't come to the sylvian fissure, doesn't come to the ventricular surface. If you just look at these mid-lesion slices, it doesn't come to the back of the thalamus either. But if you look really carefully over here, you see that there's this one spot right here at the right at the lateral geniculate, on the lateral aspect of the midbrain where it comes to that surface. And so this is going to be our target point. And the way that we get there is by using this subarachnoid cistern. It's the quadrigeminal cistern moving laterally into the ambient cistern. And the only way to make that turn into the ambient cistern from behind is to do this contralateral approach. So instead of going straight on like we do for most supracerebellar approaches, this is going to be a contralateral. So we start over on the right side, we cross over to the left, and sorry, I got that flipped. You start on the left and go to the right. And by making that crossing trajectory, it gets you further out laterally. And also, as we do this supracerebellar, you also get some advantage from starting low and aiming high. So as the cerebellum sags with gravity, you can see how we can climb higher into that thalamic region and get to our spot. So the approach here is in the sitting position. It's using gravity to open up the corridor and using those angles to cross from one side to the other. The other trick for this approach is a cut in the tentorium. The tentorium becomes a limiting barrier here for your lateral trajectory. You can only follow the basal vein of Rosenthal so far, but if you cut the tent, then you can move yourself further over and extend your reach over. And Juha, you'd appreciate this. We published a little report recently where we show how making the Hernesniemi trick, where you cut a little hole in the tentorium and use an aneurysm clip to hold up that tentorial cut, just as Juha showed us for the subtemporal approach, you can use that over here to widen your exposure. So here is the position that we use. And again, sitting position, head tilted forward a bit. It aligns things nicely. And whoops. Here's the video. So this is the exposure. This is the incision. Here's our torcular craniotomy. So it gives us a view looking over the cerebellum. We've got to cut this tentorium here to get that that view or that lateral reach. And now here's the view intraoperatively. So the first thing I do is to go inferiorly down to the cisterna magna and release CSF. And once the CSF gets released, we now have a view over the cerebellum. There will usually be some of these bridging veins that are fine to divide when they're that small. And you can see with that maneuver, we can go all the way down now to the pineal region, no surprise. But you can see how we're not lateral enough to get to this lesion. So we've got to start working ourselves laterally. Here's the basal vein of Rosenthal. We follow it in the ambient cistern from the quadrigeminal cistern. You can see branches here of the PCA coming through and branching here into the calcar and sulcus. These are our segmental arterial landmarks that we follow as we go further in. Now here is that cut in the tentorium. So you can see how the tentorium becomes this barrier for us. But by making this linear cut in the tentorium, we can release that edge there. And now we can start to tilt. We can see how we're on one side on the outside and on the inside at our depths. Let me go back to that. You can see how we've crossed from one side to the other. And that's really what allows us to get that crossing trajectory. So really important to utilize the angles here. And as we do that, we start to see a little hemosiderin staining. You can follow the arteries all the way to the lesion. And now I'm right on the lesion. So it's using the angles, using gravity retraction. And you'll see here, by going just through this little thin layer of brain tissue, we arrive here at the malformation. So there it is in full view. We've got just our small entry into the thalamus. And because of our angles, we're working upwards, which gets us from midbrain to thalamus. And you can see how we can now complete the operation. So this is a piecemeal resection. I generally like to try and preserve the capsule and remove these as one piece. This was a pretty sizable one, so you can see how we have to sometimes get inside, break it apart, and then start to work that capsular plane. And as we do, you can see it comes out nicely, and we want to be gentle on the thalamus. Here's the bulk of it. So you get inside, you debulk it internally, and you work the capsular plane, and then usually at that point you can deliver it. And here, this is what we look for at the end. We want to make sure that we've got good gliotic tissue, we don't see any residual, and that we haven't violated that gliotic plane that surrounds these. So here's just a stealth check showing that we're all the way through. You can see the angles. Let me just go back to that to show you. You can see the crossing trajectory from one side, the right side, to the left side. You can also see how on the other trajectory in the bottom right, how we have this upward inclination into the thalamus, which is really important with the gravity retraction. So really a valuable way to do this operation. And here's just our final overview showing how the cisterns have opened, the cavity of the lesion is open, and the tentorium has nicely opened for us. So postoperatively, here you can see the imaging study, and it looks real nice. So there is the first case. Here's another case. I'm going to show you this now. It's a different approach. Again, a lesion in a very similar location, upper midbrain and thalamus, But again, it's all about how it presents. And so in this one, we're going to choose a contralateral transcallosal transchoroidal fissure approach rather than the supracerebellar. And it's because it comes to the surface in a different place. It comes to the surface in the ventricle. So in terms of grading, 1 for size, 2 for age, 1 for bleeding. So it's a grade 4, still within our operable boundary limits. And this approach is going to come through the interhemispheric fissure. Again, we're going to utilize gravity. We're going to take advantage of gravity to open up our corridors. We're going to go through corpus callosum and we're going to go through choroidal fissure, and that will take us there. So here is the lesion. You can see it's large, extends all the way down to the midbrain, but comes to the surface here in the medial thalamus. And here now is our surgical view. So I'm all the way down now through the corpus callosum, getting into the ventricle. You can see foramen of Monroe here. You can see the septal vein, thalamostriate vein, and choroid plexus. So the first thing to do here is just I like to coagulate the choroid plexus. I like to kind of pull it towards myself. And you can see that as that happens, you can see the thin arachnoid layer right along the fornix. The septal vein is very small here, so it's safe to divide it. And that allows us then to follow the thalamostriate vein around its corner of the venous angle into the internal cerebral vein. This gets us to the velum interpositum. We can open up the roof of the third ventricle and follow our way into the third ventricle. And now we arrive at the lesion. You can see that the foramen of Monroe here is about twice the normal size. It used to be just this first half anteriorly. Now it's doubled in size. And that's what gives us the ability to work between the veins and access the malformation. So here, this one again has a nice capsule. We can use that capsule to get inside, debulk it internally, and then start working the plane of the capsule around it. So it's a long reach. It's a deep corridor. We're going past the frontal lobe, through the corpus callosum, into the ventricular system, and then finally reaching the thalamus. But you can see how with our long instruments and also lighted bipolars, we have the view that we need, and we have the maneuverability that we need. And let me just move this forward here. We can take this out piecemeal. We can debulk it centrally. And as we do so, this becomes smaller and smaller. And now we're left with the capsular plane. And here at the end, good gliotic margin here that shows no residual. It's really easy for these long surgical corridors to have these blind spots. So it's important to check very carefully. Here I fenestrated the floor of the third ventricle. So you're seeing here a view of the top of the basilar trunk. Again, these lighted bipolars are really nice to see all of the anatomy, and with full magnification of the microscope and good light from your instruments, you can do a nice careful inspection to make sure everything's removed. So here is the overview. You can see our venous angle, thalamostriate to internal cerebral, the widened foramen of Monroe, good preservation of the fornix here. Here's a look into the atrium of the lateral ventricle. And you can see how that choroidal fissure really becomes a beautiful avenue to get to the thalamus and upper midbrain. So here's the post-op. You can see a complete resection, large lesion completely removed, and very different approach from our last one for something in a very similar region. Now, next one. This is another midbrain lesion. Now, we're going to do a supracerebellar approach, but instead of that contralateral paramedian one that I showed you, I'm going to do this laterally. And this is another one of those workhorse approaches. So this will be a retrosigmoid craniotomy. We'll do a lateral supracerebellar transtentorial approach. And this is a grade 2 brainstem lesion. So here's the lesion. As we study this one, what you notice is that it comes to the surface here on this posterolateral midbrain surface. This is one that, if we look here in the coronal views, we see the tentorium. The tentorium really goes right to the lesion. It extends quite a bit higher than the tentorium, so that's why we need to go transtentorially so that we can get that upward extension. You can see how it goes upwards into the thalamus here. So it really is, again, one of these larger lesions that takes a little bit more. So the lateral skit or the lateral transtentorial swings the approach really to a retrosigmoid view. So you're going almost along the petrous face. You're taking it as far forward as you can. The triangular space here is what I call the infragalenic triangle, where you're under the basal vein of Rosenthal, in front of the precentral cerebellar vein, just working in this little space here. And it gives you a great view over the trochlear nerve to the lesion. So here is the video. This patient had a prior surgery by Dr. Spetzler. So that was a shunt that you saw from his prior operation. Here now is this supracerebellar view. You'll again often see these hemispheric veins from the cerebellum that bridge to the tentorium. You'll also often see some arachnoid granulations in this little corner. But this takes us now all the way down to the ambient cistern. This is the edge of the tentorium here. With gravity, you can see nice tension on these arachnoid bands. We can open the ambient cistern here. We get into this cerebello-mesencephalic fissure here, where the superior cerebellar arteries are running. Again, we're using our arterial landmarks to guide us to the lesion. And as you notice here, the dissection here is along the fourth nerve, so I'm dropping the fourth nerve. The basal vein here is when I'm following forward. And you can see right there, there's a little spot of malformation right on the posterolateral midbrain, but we're only seeing the tip of the iceberg. So here you can see a tentorial incision. This transtentorial extension is going to really open things up for us. So we cut with an 11 blade, we extend to the incisura, taking care not to cut the fourth nerve, which we've already dropped lower. And now with this little hiatus here that we've extended, what you'll see is the malformation comes into much better view. So that gives me some reach forward, more anteriorly. I can also reach higher. So this is now climbing between the, in that cerebello-mesencephalic fissure, but we're going upwards rather than downwards. And now you can see the malformation coming into view. Now, instead of just a little spot there, you can see the whole lesion as it comes to that surface. And here, we don't have to worry about safe entry because the lesion is exophytic. So we're just getting into the lesion. And as we get into the lesion, we're evacuating that hematoma. And again, this is why that grading is so valuable. When we've got a relatively fresh hematoma, we can evacuate the fluid. Here you see that trajectory. It's almost a retrosig. And we can create that working space. We take out the liquefied portion, we get to the solid portion, and now all of these perforators here stay on the outside of our capsule. We can sweep those to the right. We can pull the malformation to the left, and we can gently move that away from the nerves and the perforators. So here, more of the dissection. I'll fast forward here. Here you can see the lesion coming out. But this was quite large. We have to keep working. There's a lot of lesion. It's still up high. So you have to go into your blind spots and you have to work the lesion free. And here, again, I do this in the sitting position, so gravity is helping me. So the lesion wants to fall down, the surgical corridor wants to open, and I'm able to see what I need to see to bring all the lesion down into view. So I think that's our last piece coming out there. And now we've got to inspect. We've got to make sure that we see nothing but clean gliotic margin. We use whatever is necessary to open up that corridor. And here, post-operatively, you can see a nice clean cavity with a good resection. Now, another midbrain lesion. Here, we're going to use the orbitozygomatic approach. So for this one, we're going to come to the cerebral peduncle. Our triangle here is between the SCA and the PCA. So the SCA and the PCA form a little window here along the third nerve, and that's going to be the corridor that we exploit. If you look here, this lesion comes through the peduncle, it sticks forward into that interpeduncular cistern. And so the orbitozygomatic approach is perfect for this. It's essentially like what we use for the basilar apex aneurysm, but instead of turning medially, we turn laterally. We get into that oculomotor tentorial triangle and expose it through there. So here, just a nice Sylvian Fisher split. Frontal lobe is to your left, the temporal lobe is to your right, and we follow the MCA vessels down. We get into the carotid cistern. Here's the optic nerve. Here's the olfactory tract, just going over the optic nerve to widen things. Here now, this is just going into the interoptic triangle so that we can release CSF and get the frontal lobe moving. Here now, back to the third nerve. This is going to be the center of our approach. And we follow the third nerve back to our triangle. This is membrane of Lilliquist here. Posterior clinoid is up here. We open up all of these triangular roots. This is the carotid oculomotor triangle. This is where all the perforators are going to be. So we want to be careful here, but ultimately our triangle is going to be to the right. So here I'm to the side or lateral to the third nerve. Our SCA is down here. Our PCA is up above. And between the two, this is our lesion. So now you can see we're in the oculomotor tentorial triangle. We're between the S2 and the P2 segments, and we get right to the lesion. So this, once again, using arterial landmarks, using triangular roots, and getting right to the lesion. Here, I wanted to show this. It shows you the lighted bipolar and lighted suction. So you can bring light into the field using these instruments. They help you see into your blind spots and make sure that you've taken everything. This one took some work to get this free, so I'll just accelerate. There's a little bit of debulking, but here you really want to use a little bit of tension. So by using traction on the lesion, you can determine where this thing is adherent. You can go back in and out, breaking up those adhesions as you work them free. You want to try and preserve the capsule integrity because it helps to make sure that all of the lesion comes. And you can see here at the end, after working this for some time, we've got the capsule preserved. The lesion comes out mainly as one. And once again, we've got to make sure that we get all the lesion, preserve all the anatomy. Here's just a little tour. Here's your basilar bifurcation, perforators here off of the basilar apex. And again, a transsylvian route through the oculomotor tentorial triangle. Here is the postoperative view showing a nice clean cavity. All right, so going down to the pons, we're going to talk about this workhorse approach. This is the trans-middle cerebellar peduncle approach. It's done through an extended retrosigmoid. And I'll show you a very simple one at that. This is a grade 3, so a point for the DVA and a point for this lady's age. She presented with facial numbness, and here are her imaging studies. This is, as you can see, right squarely in the middle cerebellar peduncle. It's on the lateral aspect of the pons, and this safe entry zone here through the peduncle provides the access. So it's nowhere on the surface. It's not exophytic. It's not going to be apparent. So we have to go in and get this. And this is the classic example of an entry zone that truly is safe and that it can be really taken advantage of. So to do this technique right, you need an extended retrosigmoid approach, not just a retrosigmoid approach. you need to really understand the petrosal fissure, and you need to understand the entry zone. So let me break those down one by one. So first is the extended retrosigmoid approach. It's not just a retrosigmoid approach like we do for a microvascular decompression. It's the extended, which means, in my mind, skeletonizing the entire sigmoid sinus. By doing that, you get the dural flap to pull forward on the sinus. It takes the exposure as far forward as you can take it. And that's the real important thing. You want this as wide open as you can. Now, the second point is the trajectory. If you just do a retrosigmoid, you're going to follow the blue line and you're going to go tangentially to the lesion and really have a hard time making access. So in order to reach it, you've got to spin the axis here so that you've gone from blue to green. And to do that, it's almost like you're spinning this arrow about this point here, this pink point, and changing the trajectory. So to get to that green line, you've got to enter the tissue here really far laterally. You're not just entering here at the lateral pons, you're actually entering as far laterally on the peduncle as you can, because as you can see, if that's your entry point, then the trajectory line gets drawn directly to the center of the lesion, which is what you want. So in order to do that, you've got to understand the petrosal fissure. The petrosal fissure is like, I call it the Sylvian fissure of the cerebellum, because it separates the superior lobule from the inferior lobule right along the flocculus. And here's some anatomical views. This is the natural joining of the superior and inferior lobules. The flocculus sits right in between. And our petrosal fissure is this extension here laterally between them. And as you can see in this specimen here, the fissure opens up. And as the fissure opens up and you drop the flocculus and you drop the inferior lobule, you get a nice view of the lateral extent of the middle cerebellar peduncle. So this is that pink point that I was drawing on the trajectory figure. You want to get to this point here to make your entry. So that's this entry zone. Here it's drawn very medially. You actually want to get to it very laterally, as far laterally as you can. And let me just show you in a case. So here's the, let me go back to that. This is the retrosigmoid view here. The sigmoid sinus is at the top of your screen. The transverse sinus is to your right. And we're making our dural opening against the sigmoid sinus. You can see how when you've taken that drilling all the way over the sinus, you get right down as far anteriorly as possible. This now is the petrosal fissure. You can see this is, I picked this one because the fissure is so beautiful. The lobules create that fissure for you. You can see the branches of Ica within it. And it's just like the Sylvian fissure. If you follow the arterial segments down into the fissure, they'll separate that subarachnoid space. Here you can see the DVA. The DVA is at the very mouth of that petrosal fissure. This is a view of the fifth nerve. You can see how the DVA isolates or separates from the rest of the cerebellum. And here now you can see how our trajectory is a bit tangential. So we need to back ourselves up even further into the petrosal fissure. So I'm back in the petrosal fissure. I'm going to open this even further laterally. I'm again following the Ica, using our arterial landmarks. This is now the furthest lateral that you can go on the MCP. And you can see we're nowhere near the brainstem, but by using this as our entry point, look at how our trajectory now is squarely along the central axis of the lesion. And that's really what you want to look for. You can see how far we are laterally. And by entering at this point here, not only are we getting the right trajectory to the lesion, but we're also avoiding critical structures in the pons. So here's just a little finger of that caput medusa of the venous malformation. So as we go deep to that, you're going to see we arrived right at the malformation here. And here now we hit our target. So this is now cavernous malformation. First step is to get interior. We evacuate hematoma. Hers was fairly fresh, so that makes for a nice evacuation. We can now work that separation plane. And this is challenging as an approach because you're working through a parenchymal tunnel. So you have to sort of open up the middle cerebellar peduncle to see into that space that you've created. There's a keyhole into the malformation here that you have to then work within, and it's deep. So it is a challenging operation. I always think about this as a three-handed operation, but since we only have two hands, it makes it challenging. So you have to use your instruments as both a speculum and as an actuator. One instrument to dissect, the other to suction and keep clean. But here is a nice view of how that capsule gets preserved. The lesion comes out as one whole piece, and there's a nice overview. So once again, there's our trajectory. You can see we're at the back side of the lesion, and we've gotten all the way to the end of it. We see clean gliotic tissue. And this lady was a high functioning executive. She did very well. You can see preservation of the DVA. You can see a very lateral entry point. The pons is all the way here on the other side of the DVA. And here, inspection of the cranial nerves, just to show you how far away we are from all of those eloquent brainstem structures. And we've done that by going through this very lateral entry into the MCP. So here's the postoperative view. You can see a clean resection cavity, and again, she did nicely. Our next case, this is an inferior peduncular pontine malformation. This is one that you can see here. It's in the inferior cerebellar peduncle. You can see how it extends down into the medulla. So we're going from pons to medulla. And for this one, we're going to do a suboccipital approach. We're going to do a tilo-velar approach. This is the approach that gets us there. You can see our brainstem grading is shown here. We get no points for size, no points for crossing the midpoint. We get 2 points for age and 2 points for hemorrhage. So our total is a 4. And our approach here is going to be a midline suboccipital crani, but we're going to then take down the roof of the fourth ventricle. We're going to follow this laterally into this gutter of the lateral recess here. And these are the steps, which I'll show you. So here we are. Here's that view through the vallecula. The vallecula is the space between the tonsils. We get down on this caudal loop of pica. As we follow the lesion inward, we're taking down the velum of the fourth ventricle. You'll see I've placed a little thin retractor blade just to hold the tonsil over. And as we continue our march laterally, we're opening up the lateral recess. The midline is hidden over here. Here we're seeing this sulcus limitans here on the floor of the fourth ventricle. And here now is our entry point. So the inferior cerebellar peduncle is climbing into the peduncle at this spot. And as we open this up, we get right to the lesion. All we have here is a little bit of a stain to guide us. But here you can now see working our way inferiorly into the medullary space. And here with our round eyes, here's a nice view of the lesion here coming into view. Now I've got a handle on it. We can use that traction technique to define its adhesion points. And here, here's a nice view once again, getting to that lower extent, working it free. And finally, taking it out. So here's just an overview of the anatomy. Nice view of the vert, the cranial nerves over the top. And here's a view to the contralateral side. So here, just some of the anatomical points, which I'll skip over. And postoperatively, you can see here, this is the clean resection cavity. All right, so let's see. It is 5 minutes to 6 o'clock in the morning my time. So let me wrap this up here. I'm going to jump ahead now here to some of my concluding slides here. So, I think when we talk about surgery of the brainstem or these brainstem cavernous malformations, a lot of it is just really careful decision making. You want to be careful about the patients you select, and I have found the grading scale to be helpful. Using those low and intermediate grade lesions as the ones that you select for surgery, being careful with the higher grade lesions. The other critical decision is your approach. You want to pick your approach very carefully so that you optimize your exposure and optimize your access to the lesion. So this is just a real summary slide. There are many approaches that you can take to the midbrain. They're listed here with the craniotomy and the approach. The ones here with the check marks are some of the ones that I've shown you. These are the real workhorses. Each one takes you to a different spot. The orbitozygomatic transsylvian is great for these peduncular lesions. The transcallosal transchoroidal fissure is really nice for the ones that are in the third ventricle or upper midbrain, accessed from above. The lateral supracerebellar accesses the tegmental lesions on the lateral aspect of the midbrain. And finally, the midline skit is ideal for these quadrigeminal lesions that are in the back. As we change our attention to the pons, you can see the four workhorses here are the trans-CP angle, which is the traditional approach that gets to the anterolateral pons. The trans-MCP gets you to the truly lateral pons or the pedicular lesions. The suboccipital transventricular approach will get you to the floor of the fourth ventricle, but I use this sparingly because of the eloquence of the floor. And then finally, the transpontomedullary sulcus approach, one that I haven't shown you. I love this approach. It gets you to that underbelly of the pons for what I call the supraolivary lesion. And these are the four workhorses for pons. For the medulla, much simpler. This is a much smaller part of the brainstem, and our choices here are either transventricular, square on with the suboccipital, or going laterally with the T-lobular approach. The far lateral is the other workhorse. When you have a lesion that comes to the surface more laterally, you want to go transcisternally and go in that direction. So those are the menus of approaches. And again, my last slide here, patient selection is the secret. You want to look for patients that have had a hemorrhage and have neurologic deficit. You want to look for lesions that are on the surface, either on the pia or at the ependema. You want to approach and enter safely. This idea of safe entry is, I think, in general, overstated. So you really still want to look for lesions that are on the surface or exophytic. But if they are just below and you have a safe entry spot, know your anatomy and use that carefully. Intracapsular resection, I think, is important. You want to try and get these things out in as few pieces as possible. If you need to break it up, you can go internally first, but try and keep the capsule intact. It helps to make sure that everything pulls out as one. And then lastly, is this idea of the fine line. The fine line is that line between getting all the lesion and causing morbidity. If you are too aggressive with your resection and you get into the brainstem, then you're going to have complications in unhappy patients. So you want to be cautious, but on the flip side, you don't want to be incomplete with your resection and have residual lesion that causes recurrent hemorrhage down the road and necessitates reoperation. So this is that fine line. And I think this is one of those kind of art of neurosurgery where you just have to learn how to balance the two, be as aggressive as you need to be, but be also very mindful of what you're doing to the adjacent brainstem. So with that, I am going to stop my screen share and open it up for questions. Thank you.
Thank you, Michael. Wonderful lecture. Very thoughtful approaches and very skillful surgery. Wonderful results. So I open the discussion. Please go ahead.
Yeah, Mike, that was a fantastic presentation. And there is no question that these cavernomas are difficult lesions. And to remove them nicely and beautifully is a curative. You cure the person. So there is a fine line, all right, but there is a fine line between curing the person and leaving him to the danger. So to do a good operation, to do a beautiful operation is what is you have been talking about. Now in your concluding slide, which tells a huge lot, one thing is you mentioned about patient selection. And the second thing you mentioned is the lesions surfacing to the pia and to the ependyma. Now, I want you to clarify this issue a little bit more because there are too many questions I see on the screen pertaining to this. What are your defining indications for surgery and what are your defining indications not to do surgery? Can you, is the lesion coming to the ependyma or to the pia? Is it defining or you, what do you mean by this?
Yeah. I think there's a lot there. It's true you want to try and select the patients that, first of all, are symptomatic. It doesn't make sense to operate on an asymptomatic patient who's never bled or never had any kind of deficits because you'll only make them worse. So first and foremost, you want to make sure that you're selecting patients that are symptomatic, have had hemorrhage, and clearly need this. Now, there is this sort of strange practice where people who've had a hemorrhage, others will wait for a second hemorrhage to operate. And I think that, it's been something that I've never really fully understood. If somebody comes in with a first hemorrhage and you've got a lesion that's accessible, that's on the surface, then I see no reason to wait for a second hemorrhage to take them to the operating room, because with each hemorrhage, they have losses and new deficits, and it just doesn't make sense to subject them to that. So I look then for lesions that are on the pia. Now, the MRI has really become a game changer for us because you can see very clearly the anatomy in exquisite detail. But an important point is not to be fooled by the T2 weighted sequences. The T2 weighted sequences over exaggerate the lesion size, and they may not show you that there's tissue between the pia or the ependyma and the lesion itself. So you really have to be meticulous about studying just the T1 and use very thin cuts to see everything that's there. So I think it's a combination of knowing the patient, studying the MR anatomy, and then asking yourself, is there a surgical route that gets you there safely? There are lesions that I don't operate that are, let's say in the center of the pons and have no part of it touching that surface. And I know that for me to go through viable tissue to get to that lesion will hurt the patient. So those are ones, for example, that I won't operate. If I don't see a safe entry zone and it's completely surrounded, then I'm conservative. If it's on the surface, there's almost no place that you can't get to that's safe. If it's on the surface, then you don't have to transgress tissue. And so when it does come to the pia, when it does come to the ependyma, it's very hard to say no to these patients, particularly if they've had those symptomatic hemorrhages. So this is sort of the best answer I can give you, Atul. They're all so different. Every patient's presentation is different. Some come in with very mild symptoms, some come in with very severe symptoms. Some are right on the surface, some are a millimeter below, some are 5 millimeters below. And, you know, there's really no easy way to give you a formula for that. I do think the grading system can be helpful because clearly the bigger ones, the deeper ones, the ones that are scarred in, that have had 2 months to sit, those are going to present much more challenge and higher risk to you as the surgeon. So those can be helpful. You know, if you get a grade 6 or a grade 7, and the patient wants that out, that may be one of those that you say, well, wait for that next hemorrhage, because right now your numbers are too high. And the interesting thing about the grading system is that it's dynamic. There's that component of not only age, which can change, but also hemorrhage. If you have 2 points assigned for the hemorrhage, but you wait for a new hemorrhage, you all of a sudden can subtract 2 points, and it can change your number dramatically. And so you can see how it unlike an AVM, the grading for the cavernous malformation is dynamic and will change, and can also be a guide for you.
Another thing, Mike, another question is, you see, you have shown beautiful surgery, beautiful technique, and all those things. Now, I want to know, in your very big experience, there must be some patients who developed postoperative diplopia, and they must be very unhappy patients. Postoperative facial weakness, postoperative sixth nerve weakness, postoperative eye coordination disturbance, postoperative hemiparesis, postoperative ataxia. So can you just, how frequent these complications are in your huge series? Do they come, or do they never come, or do they come but they improve, or do they, what is the scene?
Yeah, I think it's an interesting question, because there's some complications and deficits that are really difficult for patients, and others that are not. You mentioned the double vision. That's a really hard one for patients. And I have developed tremendous respect for the medial longitudinal fasciculus, or MLF. That runs in the floor of the fourth ventricle, just on either side of the midline. It's very thin. It coordinates the third, fourth, and sixth nuclei, as we all know. And that is a very bothersome structure to interrupt. So I actually today use far fewer transventricular approaches to the pons or medulla than I did 10 years ago. And it's because I've seen too many of these patients that are harmed by an approach that comes too close to the MLF. So I'm using much more the MCP, the middle cerebellar peduncle approach, because you can get to the pons much safer. The ataxia that patients get with a trans MCP approach is transient and really quite mild. So yes, they may have some clumsiness in the first week or 2 weeks post-operatively, but it goes away. The MCP is an input bundle into the cerebellum. It's not an output channel. There's a huge difference between input and output. And you know, if you work within the MCP, patients actually do quite well and have very transient problems that don't become permanent problems. Whereas, for example, the outflow peduncle, the SCP, superior cerebellar peduncle, is a devastating one to get into. The things, obviously, on the front side of the brainstem, the corticospinal tract is one of those super eloquent no-fly zones. I'm particularly cautious there as well. So I don't frequently use the transsylvian trans-peduncular approaches like I showed at that one case, unless they're really quite blatant. That one I showed you, it was coming out through the cerebellar peduncle that pushed the corticospinal tract to the side. There's an example where you can do that safely, and the patients will be fine. They often will get some new transient deficits. I would say that we see transient deficits in probably a third of our patients in the brainstem. but these go after, you know, a couple of weeks and some rehab. I think the rate of permanent deficit is much lower. Again, it varies, but in general, we have found about a 15 to 20% rate of permanent new deficits with many of these patients in the series overall. So, you know, again, it's careful selection so that you keep your number in the teens like that.
Thank you, Mike. Thank you. That, you know, another thing is with cavernomas, many of these fellows come with a bleed and they come in a very, you know, they come in a situation where they have remarkable deficits and they improve and they come back to life. So the improvement is also very magical in these and very gratifying for the surgeon. Don't you think? It's so gratifying. You see an unconscious patient, you see a decerebrate patient, and you see him walking around and, you know, coming back to life. I think cavernoma surgery is a very, very gratifying surgery. Absolutely beautiful neurosurgical tool because there is no radiation or anything else that can work here. The question is, and the bottom line is to do it and to do it properly. And that is what you have shown with such articulation and beauty. And Mike, for your teaching, thank you very much.
Thank you, Atul. I think you're right. The bleed pattern for these is much more gentle on the tissue, and it's a venous hemorrhage, so it's slower. It's not as destructive as an arterial hemorrhage that you get with an aneurysm or with an AVM. And when you have a lower pressure bleed that is slower, it pushes the tissues and the eloquence to the side. So I think the recovery is much better in general. We see the same things with cavernomas as we do with AVMs in terms of the younger patients doing better and having more plasticity, more resilience. So I think, you know, a take home is that even if you get patients that look quite grave coming in, it's good to be aggressive because they'll surprise you.
Thank you, Mike.
I have operated many cases very acutely within first days, within 3 days after bleeding. So according to your grading system, this might be a good thing because those operated on very early, they get 0 point according to your grading system. Those, like the old tradition has been, at least in Europe, that you wait with you make a new MRI in 2 months and then consider surgery. So I did differently. I operated most cases very soon after bleeding, and I, like Atul told, many good results in unconscious patients. They were like miracles, waking up and making good recoveries. So what is your thinking?
Yeah, so I agree with you. I think operating early in that first 3 weeks is very valuable. One of the things that has frustrated me, though, with that particular point, and I couldn't come up with an answer for it or a solution, was that, you know, if you look at the grading system, you get no points if you operate between day 0 and 3 weeks. But I think there is a difference within that time period between like the first couple of days and the latter part of that window, because when you operate like within 24 hours or within even like 72 hours, you have brainstem edema, you have blood clot that hasn't liquefied. It's sometimes difficult to differentiate the malformation itself from the clot, so you can get lost within the space of the cavity. And so I think it's a difficult thing to operate in those first couple of days. However, if you allow that liquefaction process to happen, and that usually takes about a week, then that becomes the perfect time in my mind, between 1 week and 3 weeks. We just couldn't get that nuance into the grading scale. But I think for those who've been there, I think you all understand it. It's a lot more difficult to go into a thick tenacious clot that's intermixed between your cavernous malformation and one that has already started to liquefy, but is still within that 3-week period. So for me, if I can wait out those first 3 to 5 days and just let the patient simmer, then I think that's better. But I do think that there is a real advantage. We saw that in our data, and our statistics bore it out that if you operate in that 0 to 3 week window, it's much better than if you operate in the 8-week or beyond window.
Did you have any patients who were deeply unconscious who came to you for operation on the first day? So this is
yes.
because you have maybe tertiary center, you don't get that kind of patients.
No, I've definitely operated on those patients, and you're right. I think in those cases, yeah, you bite the bullet and you just do a decompressive emergency operation because the patient's so critical. There are those types, but I would say that they're much more rare. I mean, most of the time you get patients that come in with sudden deficits, but they're conscious, and you know, they may be hemiparetic or hemiplegic and new cranial nerve constellations, but they give you some comfort in waiting it out a few days. So I think you know, in those cases, it's good to wait.
Okay. Marcelo Platas from Argentina was asking about the timing. I think this question was answered. So there are some other discussion.
Yeah, just take a look on the panel there, Juha. Do you see any questions you think that would be good?
I saw only this one.
Okay, here's one from Nikolai Melita. Professor Lawton, what is your vision about the future of connectomics and AI for avoiding complications after surgery?
Yeah, well, that's a very interesting question. I think the connectomics, it's a really interesting story. Maybe not so much in the brainstem, because the brainstem pathways have been studied so well for so long that we have a good handle on that. But I think the connectomics in the cerebrum are becoming very interesting. There's so much going on there with the white matter fiber tracts that we don't understand. You know, even let's just take the supplementary motor area. There's an area that we don't give a lot of respect for because it's in front of the motor strip. But when you get into that area, you know, you really do some things to patients that we don't fully understand. And I think the connectomics is interesting because there are all of these other networks that we're discovering, like the default mode network, the salience network, these other systems that are at play that we're only now starting to understand. And I think as our understanding grows of those networks and what they do exactly, then I think, you know, probably 20, 30 years from now, the cerebrum is going to start looking a whole lot like the brainstem looks to us now, where every little bit of it has some discrete function, and we're going to start treating it with a larger measure of respect that we don't give it. Right now, you know, if you get a frontal cavernous malformation, most of us would view that as a non-eloquent lesion, and we would go through brain tissue to get to it, and we would take it out without thinking. But you know, again, as connectomics tells us about these other networks, I think we're going to be thinking twice about it. The other component that's interesting is, you know, I talked a lot about the decision making, and you see how the decisions really vary incredibly based upon these really small, subtle, nuanced differences from one lesion to the next. And I think that's where AI can actually be helpful. You know, a computer might pick up on the fact that a lesion comes to the surface in the ambient cistern under the thalamus, in a way that's better than, let's say, going through the third ventricle. And I think if we develop the tools, the AI for that, then I think we can run our cases through this machine and get a preliminary read, just as the radiologists now in some centers can get an AI read that they then validate with their own eye. So I think that day is coming, and we're actually trying to play around with this concept. So I think the short answer is stay tuned. We're gonna have something nice within a couple of years.
Red up, you had a question? Please go ahead. Red up.
Yeah, yes, thank you, Professor Juha, and thank you, Dr. John, Professor Atul, Professor Lawton. Thank you for the extraordinarily invaluable presentation and shared experience. So make it brief. If you would please tell me what's your preferred approach and treatment for the spinal cavernous malformation, the spinal cord cav-mal. Would you go directly for surgery, or do you prefer for the second or third bleed from the patient, or it's a clinical judgment?
Yeah, it's a good question. I view the spinal cord cavernous malformation exactly the same as the brainstem cavernous malformation. You want to wait for symptoms. If they present with symptoms, I have no problem operating after the first bleed. It's a similar analysis. You want to look for where it comes to the surface. There are regions of the spinal cord that are very forgiving, the safe entry zones, if you will, and I think the big one is the median raphe. You can do a midline myelotomy and get to a central spinal cord lesion very safely with minimal impact. So it gives you that safe entry. Now, that's not the same for the more laterally placed lesions. The dorsal root entry zone lesion is a spot that you can get to. You can access that nicely and safely, and same with the lateral lesion that's at the level of the dentate. So there are a couple of key places on the spinal cord that I think are very accessible and very safe to get to, and I will be aggressive with those. There are others, that are anteriorly placed and will require much bigger surgical approaches to get to, or significant cord rotation to get to, that I will be conservative. But I would say generally the spinal cord is easier to work with and more predictable. So I do tend to be aggressive with those.
Thank you, Professor. Thank you.
Some more questions?
No, just to congratulate Professor Michael Lawton. Really impressive and amazing surgical procedures. So with this, we know that one of the most important things is to know microsurgical anatomy of brainstem. So greetings from Mexico.
Thank you. Thank you. Yeah, as I've written this 7 Cavernomas book, I have to say that it's forced me to go back and study my brainstem anatomy in ways that I hadn't done since being in medical school. And what's enjoyable about it is how when you really have a good feeling for the circuitry of the brainstem and the nuclei and the tracts, it's fascinating then to relate that to your clinical exams and your patient presentations. And it's a beautiful area. I think it's well worth it just for all of us to spend a little time. You can be a brainstem cavernoma surgeon and not pay any attention to all of the different nuances of the circuitry, but when you do, you really learn a lot about how things are wired, what you're getting away with and what you're not getting away with.
Okay, Juha?
Okay, we thank you very much, Michael, for excellent, fantastic lecture. And we are waiting for the new book in the 7 series, 7 Cavernomas. When will it come out around?
Well, I'm doing something a little different this time, Juha. I realized that when I wrote the other books, I'd spent all this time writing and writing and writing. And then at the end, you get this release of a book and it feels good, but all that time spent, there was no peeps or no release. So this time we're actually releasing doing the book as a series of journal articles with JNS. And the first one comes out, I think it's in August or September. And it'll be a series of journal articles so that everybody can have access to it. And at the end of it, I'll put it all together as the book. So
Okay.
very soon, very soon.
Okay, great. Thank you, Michael, for your
Thank
time.
you.
And Juha, we can wrap it up. What's for next week, Juha?
I have to discuss.
Okay.
Next week. There was one cancellation, so I have to discuss.
Okay, very good. Okay, we'll see everyone next week. Thank you, Michael, again.
Thank you very
Thank
much,
you.
Mike.
Thanks for having me.
Thank you, Dr. Michael, Professor Michael.
Bye,
Dr. Juha.
everybody. Thank you.
Thank you, everybody.
Liao.